Hi everyone, we are going to see about encephalitis today. So what is encephalitis? What is the difference between encephalitis and meningitis? As we know, meningitis is infection in the meninges, which is the surrounding of the brain, whereas encephalitis is the brain tissue is infected. So encephalitis could be because of a virus, whereas mostly because of a virus, whereas meningitis could be because of virus or bacterial. And meningitis, if it is because of viral, it's usually milder, whereas encephalitis is always a medical emergency, and the symptoms would be more of consciousness oriented in encephalitis. The patient will have confusion, seizure, personality changes, whereas a classic symptom of meningitis is neck stiffness, fever, and headache. So we are going to see about 3 encephalitis here in this talk today, which is varicella zoster virus induced encephalitis, post chickenpox, or HSV encephalitis, and Japanese encephalitis. So first, coming to the cause. Not everyone gets encephalitis post chickenpox, but few people who are immunocompromised can get it. So chickenpox is because of varicella zoster virus, and how it is spread is it's highly contagious, and if you have got chickenpox, most of the time you will not get it again, but sometimes rare cases, if your immunity is low, you can get it. And if somebody is infected with chickenpox, then if you come in direct contact with the rash, you can become infected, or respiratory droplet, or touching contaminated objects used by them like clothing, bedding, and surfaces which has the virus. And it is highly contagious, as we discussed before. Usually the infectious period is 1 to 2 days before the rash appears, and until they have crusted. The patient should be in isolation if they are in the hospital. 5 to 7 days after the rash starts, they should be in isolation. So, comparing this with HSV encephalitis, if a patient is admitted with suspected HSV encephalitis, they need not be kept in isolation because it's not transmitted person to person during the encephalitis phase. This is a DNA virus, herpes simplex virus, and how it spreads is the patient during their childhood, they might have had a primary infection like a cold sore over their lips or oral mucosa, or they might have a genital herpes, which we will discuss later. And after some, herpes will travel up the sensory nerves, and it will be latent in the trigeminal ganglia near the brainstem. Sometimes when the patient's immunity is reduced or when it is triggered by stress, there will be reactivation of this HSV virus, and it will spread to the brain. That is when the patient can get HSV encephalitis. So if you suspect HSV encephalitis, you need to ask a history of cold sore in their lips or mouth, or genital herpes in the past. Only people with that will get HSV encephalitis. Whereas Japanese encephalitis, it's caused by an RNA virus called flavivirus, and it is mosquito bite borne. It's because of a Culex mosquito which bites an infected pig or a bird, and it picks up the virus from them, and then once this mosquito bites a human, they can get Japanese encephalitis. So person to person transmission doesn't happen. If a person has JE, if a mosquito bites, it's because of a mosquito bite from an infected pig or a bird, and then to the human. So person to person transmission does not occur. So you need not isolate a JE patient also. So coming to herpes infection, as we discussed before, it could be because these herpes encephalitis will happen to people who have had genital herpes in the past or cold sore. So to know more about genital herpes, it's caused most commonly by HSV2, or if the person is involved in oral sex, by HSV1. and it is because of skin to skin contact during sex even without penetration. Whereas cold sore is because of HSV1, and it can be because of kissing or sharing utensils or oral contact. And only these patients later in their life can have HSV encephalitis. And just a quick question, why do you think a Japanese encephalitis patient should not do organ donation? Because this virus, it's obviously an infection, and it is active in the blood and the tissue. So organ donation is contraindicated in Japanese encephalitis. Whereas a HIV patient can donate organ to another HIV positive patient thanks to all the antiretroviral drugs available now. Okay, so coming back to the differences in all these three encephalitis, let's first see about the investigations. First, LP is the foremost. I'm not going to talk more about the symptoms because all these patients will have nearly the same symptoms. That is going to be a fever, seizures in HSV encephalitis or JE, and neurological altered mental status. All these symptoms are going to be the same. But coming to investigations, when you do an LP, the glucose will be high or normal in all the viral encephalitis which we see here. So glucose may be either high or normal, whereas if it's a bacterial, then the glucose will be low and lymphocytes will be high. So this is also going to be same in all the three encephalitis. And CSF can be normal in early disease. So chickenpox, that is varicella zoster virus encephalitis, the gold standard is a PCR for diagnosing the varicella zoster virus DNA in the CSF. Whereas CSF IgM for VZV, varicella zoster, is less commonly used, but it could be supportive because it would just, IgM would just say that the patient might have had an infection, but a PCR is gold standard. An MRI brain may show areas of inflammation but not very classic, it could even be normal. Whereas in HSV encephalitis, the LP is going to be the same, and the gold standard is going to be a PCR to find out the HSV DNA. And in early cases it can be negative, but if you highly suspect, you can repeat it after 7 days. But HSV, IgG and IgM is not significant, because IgG could be positive if a patient have had cold sore or a genital herpes in the past. So that will not give you much of an idea. But gold standard is PCR for HSV DNA. And meningoencephalitis panel would check the blood for it's just a panel where you send the blood for all the HSV, and also you check all the viruses in that in the blood. So that will also give you a clue to see if there is HSV or not. But the gold standard is going to be a CSF sample for PCR of HSV DNA. EEG may tell focal abnormalities in the temporal region. HSV encephalitis is more common in the temporal lobe involvement. So in the MRI, you can have hyperintensities in the temporal lobe. Whereas in Japanese encephalitis, LP findings are going to be the same, and the gold standard is going to be Japanese encephalitis IgM in the CSF. An MRI brain sometimes will be normal, and sometimes it might show bilateral thalamus involvement, which is very classic for Japanese encephalitis, or basal ganglia or brainstem involvement. Treatment is the same for all the three. Same for all the two, which is varicella zoster virus encephalitis and HSV encephalitis, which is going to be acyclovir 10 to 15 milligram per kg IV every 8 hours, and renal dose adjustment is required if there is an AKI, and it's given for 14 to 21 days If it's just chickenpox, they can give for 7 days, but because if it's encephalitis, 14 to 21 days. And that's going to be same for HSV encephalitis. And seizure control, IV fluids, and other supportive care. Whereas for Japanese encephalitis, it's only supportive care and it's a worse prognosis even with care. Chickenpox, if you have not got chickenpox in the past, you can get vaccinated to get an infection. But once you have been exposed to a patient with chickenpox, then obviously vaccination will not be of much use right now, because for the vaccine to work will take time. HSV encephalitis has no vaccination to prevent it, but JE you can give vaccine. Up to 15 years, JE vaccines can be given, which is 2 doses. And the prognosis is better for HSV encephalitis if you treat it early with acyclovir, whereas worse with Japanese encephalitis. Thank you.